Good afternoon, ladies and gentlemen. It's a great pleasure to welcome all of you to this session. And in this session, we are basically going to solve all the world's problems in HIV treatment and tell you how to treat all and how to make it happen and how to afford it. So when you walk out of here, you should have all of the world's burdens on these questions lifted from your shoulder. Okay, so now let's get real. It's a great pleasure to have all of you. We're going to be debating some of the key issues in the challenges in trying to treat all. And we have a lineup of speakers in this late-breaking session who are going to share some of the latest data that's available. Without further ado, it's my great pleasure to introduce my co-chair, Dr. Gottfried Hönschel, who is our fearless leader in the world as we take charge of working out how to respond to the global HIV epidemic. And one only needs to look at the quality and the depth of the recent guidelines that have come out of WHO to know what a sterling piece of work he and his team are doing. So it's my great pleasure to hand over the mic to Gottfried Hönschel.
Thank you very much, Slim, and you're very kind. Good afternoon, colleagues, friends. Based on groundbreaking research started in Timbrano, as you will all recall, in December 2015, WHO recommended treat all. The guidelines were released in full in early 2016. We just reviewed what the policy uptake is, and it's quite impressive. 122 countries have treat all written into their national policies. And on the history of the many recommendations that have been made, probably this is the one that has the most rapid and most impressive uptake. We also, of course, need to move now from policy to implementation. If we look at implementation, 19.5 million people are on treatment. That's obviously something we celebrate. We look at the Cascade, the data that we've all seen, 70, 77, 82, looks very good. But the glass is still half empty, half full, I would say. 70% means that 30% do not know their status. So we really have to find ways of reaching these people. We also really need to look at, if we see what is the population viral load suppression among people being HIV positive, it's just 44%. So clearly, we still have a very long way to go, and we really have to find the best and smartest ways of implementing treat all and addressing some of these challenges that will come up in this afternoon session.
Thanks very much, Gottfried. So without further ado, let me invite our first speaker in the session to come and give us some framing remarks. And we all are aware of the important role that the Global Fund plays as we take on the challenge of treating all. And we're very honored to have with us in our midst today Marijke Windrongs, who hails from the Netherlands, where she has been involved in various diplomatic postings in Bangladesh, El Salvador, Uganda, South Sudan. She knows the world, and she brings to the Global Fund her broad experience in social development, and she is currently the interim executive director of the Global Fund. Over to you, Marijke.
Thank you very much, Salim. According to the UNAIDS report that was released last week, there's 19.5 million people currently in treatment, the first time that we passed the bar of having more than 50% of the people who need it on treatment. The UNAIDS report also indicated some good progress in a number of countries with increased scale of treatment and promising declines in incidence. And yesterday, PEPFAR launched results from 4 countries that demonstrate that they have reached the 1990. There's declining incidence, and we see that countries are getting and starting to get control of their epidemics. And funding has increased. And last year, 19 billion was available for global HIV. But there's a lot of buts if we look at these successes that have collectively been achieved. Because there's still a funding shortfall of 7 billion annually to meet the 26 billion that's needed to estimated by UNH. And we know as countries successfully scaling up treatment, they're struggling on how to make sure that people access treatment, and there's funding available for community groups, for key populations, for system strengthening, and all the other and prevention efforts, not to forget, and all the other things that need to be funded. And countries struggle on how to deal with shortage of funding. We've also seen that even though the overall funding levels did increase, most of those increases did come from domestic resources. And last year, for the first time, domestic resources contributed to 57% of overall funding. External funding, Kaiser Family Foundation reported last week, has declined in 2016 for the second year in a row. And part of that can be explained by artificial factors like the currency exchange and strong dollar. But also part of it was real declines in funding that's available from external resources. And when 53% of people access treatment, it also means that 47% of people do not access treatment. And we know that we're missing out important groups on a very large scale. Young people, key populations in almost all settings, and ironically, men. So yes, we should, if we are serious about our commitment to end AIDS as a public health threat, that we should be able to treat all and fund and afford it and make the funding available to do it. But there's a number of really important criteria that have to be met and that we need to work on vigorously, collectively over the next couple of years. Political commitments, globally and at country level, to make sure that the funding will be made available from domestic resources, from external funding, from other sources of funding, and to radically move towards evidence-based programming, get rid of stigma and discrimination, get rid of criminalizing key populations, and remove barriers to access. Also, we need to think about innovations. We need to innovate in new treatment options that are easier for people to adhere to. We need to innovate in prevention options that better need the people that need the most. And we need to innovate in the way we deliver services to make sure that the services address the needs of the populations. And with this introductory remarks, I would like to conclude. I'm really looking forward to the panel discussion. Thank you.
Thanks very much, Marijke. It's my pleasure to introduce the first speaker with a full presentation, sorry, Marijke, who will talk about the wide-ranging real-world impact of a policy change on treatment eligibility on ART initiation and retention in care in Zambia. And the speaker is Alok Moody, who is an infectious disease fellow at UCSF and based at the Center for Infectious Disease Research in Zambia, and does obviously research on implementation issues. Alok, please.
Thank you very much for this opportunity to present this work on behalf of all my co-authors. The title of the talk actually changed a little bit, so now it's the impact of expanding treatment eligibility on ART initiation and retention in care in patients with a CD4 greater than 350 in Zambia. The real-world effects of expanding ART eligibility as we move into the era of treat all are difficult to know. RCTs demonstrate efficacy in well-controlled environments, thus making extrapolation to the real world uncertain. The positive effects of expanding ART eligibility may be both direct and indirect, and these should both be quantified to sharpen our understandings of the benefits. Similarly, negative spillover effects, such as increased congestion at clinics and crowding out of patients, should be identified to minimize unintended consequences. Real-world program data is the most relevant for answering these questions, but causal inference is often limited with observational data when using traditional methods. Quasi-experimental study designs offer an underused strategy to address these challenges by approximating experimental conditions in real-world data. An example of this is regression discontinuity, which has been previously used in South Africa to assess the effects of ART eligibility in those with a CD4 below 350. In December 2016, Zambia adopted universal treatment, but prior to this change, it had changed its HIV treatment guidelines on April 1st, 2014, to expand ART eligibility to include patients with the CD4 between 350 and 500, as well as pregnant and breastfeeding women and their partners under option B+. We leveraged this 2014 change in Zambia's HIV treatment guidelines in a quasi-experimental study designed to shed light onto what might be expected when expanding to treat all. The objectives of our study are: 1, to estimate the real-world effects of expanding treatment eligibility on ART initiation or retention and care, and 2, to quantify the effect of ART initiation on retention and care in patients with high CD4 counts. Our study population included ART-naive patients greater than 15 years old that newly enrolled in HIV care 7 months before and after this change in Zambia's treatment guidelines. We excluded patients enrolling within 1 month of this change to account for a transition period as the new guidelines were being rolled out. We looked at patients enrolling at one of 64 clinics supported by the Center for Infectious Disease Research in Zambia, or CIDRS. Our measurements were obtained from the Better Info for Health study, which is a Gates-funded study using sampling-based tracing to ascertain outcomes in patients lost to follow-up. And we also used data from the electronic medical record system used in routine HIV care in Zambia called SmartCare. We used a regression discontinuity design to estimate the real-world effects of implementing these new guidelines. For this study design, we compare patients enrolling just before and just after the change in guidelines. As the rollout date is arbitrary, we can assume that patients enrolling before and after will be similar on both measured and unmeasured characteristics, thus making assignment to exposure as random. Our 3 main outcomes were: 1, ART initiation within 3 months of enrollment; 2, retention and care at 6 months, which we defined as having made at least 1 visit between 3 and 9 months post-enrollment; and 3, a composite outcome of having started ART at 3 months and still in care at 6 months. We then used a local linear regression adjusting for CD4, age, and gender, and then also weighted patients proportional to how close they enrolled to the cutoff to strengthen the validity of the underlying RD assumptions. We also conducted sensitivity analyses varying the bandwidth around the cutoff, as well as the length of the transition period to ensure the robustness of our results. Those results are not shown here, though. Next, we leveraged this RD design and used implementation of new guidelines as an instrumental variable to estimate the real-world effects of ART initiation on retention and care. The benefits of an IV analysis is that it can provide unbiased estimates even when there's unmeasured confounding between a treatment, in this case ART initiation, and the outcome, retention and care, under certain assumptions. 1, the instrument, implementation of guidelines, is associated with the treatment. 2, there are no common causes of the instrument and the outcome. And 3, the instrument affects the outcome only through the treatment of interest. In this situation, we can estimate the effect of ART initiation on retention and care for those patients who started ART in response to this change in guidelines. This is also called the local average treatment effect. For our analysis, we defined 3 patient subgroups which were defined irrespective of the actual date of enrollment. First group were always eligible patients who would have been eligible by the 2010 guidelines at enrollment. These are patients who had a CD4 below 350, WHO stage 3 or 4 disease, or active TB. We were unable to identify patients with serodiscordant partners or patients with HBV co-infection and severe liver disease who also would have been part of this category due to some limitations in the data. Our second subgroup were newly eligible patients who would have been eligible by the 2014 guideline. These are patients who had a CD4 between 350 and 500 or were pregnant or breastfeeding women. We were also unable to identify partners of the pregnant and breastfeeding women due to limitations in the data. And then our last subgroup were not yet eligible patients who had a CD4 above 500 and would not have been eligible by either the 2010 or 2014 guidelines. About 32,600 patients newly enrolled during our study period, and 23,600 were included in our final analysis. Newly enrolling patients had a median CD4 of 267, and about 70% of them would have been eligible by the 2010 guidelines at the time of enrollment. This slide is quite dense, but the main takeaway is that within each patient subgroup, patients enrolling prior to the change in guidelines were very similar to those who enrolled afterwards, helping to verify the underlying assumptions of the RD analysis. On this slide, we also see that the number of new patient enrollments as well as the patient distribution remained essentially unchanged before and after the guidelines were rolled out, also helping to verify some of the key assumptions of the analysis. On this slide, these first set of slides show the results from the RD analysis in the always eligible group. The x-axis shows the time since the guidelines were rolled out with the dotted line representing the date of implementation, and the y-axis shows the percent of patients with the outcome, in this case ART initiation at 3 months. As you can see, implementing new guidelines did not affect ART initiation in always eligible patients. It also did not affect retention and care in these patients, nor did it affect the percentage of patients who were in care and on ART at 6 months. However, for the newly eligible patients, implementing new guidelines increased ART initiation at 3 months by 38%. It also significantly increased retention and care at 6 months by 7%. And it also increased the percentage of newly eligible patients in care and on ART by 29%. These last set of slides are for the not yet eligible patients and who had a CD4 above 500. In this case, implementation of the new guidelines, interestingly, also increased ART initiation at 3 months by about 14%. But it did not significantly affect retention and care, and it did increase the percent of patients in care and on ART by 9.4%, even though they were still not eligible. Here we see the overall effects in the total patient population. There was a 9.7% increase in ART initiation, a minimal effect on retention and care, and a 7.4% increase in the percentage of patients in care and on ART. Lastly, we have the results from our instrumental variable analysis. In newly eligible patients, initiating ART increased retention and care by about 26.9%. This effect was more pronounced in patients newly eligible due to CD4 count, a 29.3% increase in retention, compared to those newly eligible due to option B+, an 18% increase. Additionally, we estimated that ART initiation also increased retention and care by 29% in patients not yet eligible for ART with a CD4 above 500. There are several limitations to our study. First, we were unable to assess virologic suppression. The recent results from Zambia presented today do suggest that just under 90% of patients on ART are also virologically suppressed in Zambia. Two, there are inherent limitations to our primary data source, and though we did conduct chart reviews and sensitivity analysis to validate the categorization of our patients, there is still some potential for bias for misclassification. And lastly, there's also potential bias due to patients crossing over from the pre-guideline period to the post-guideline period. Though we anticipated this would lead to a conservative bias, and our sensitivity analysis also suggested any bias was negligible. In conclusion, we found that expanding ART eligibility led to overall positive effects in those with a higher CD4 count, without any negative spillover effects in those with lower CD4 counts. In newly eligible patients, ART initiation increased by 38%, retention and care at 6 months increased by 7%, and the percentage of patients in care and on ART at 6 months increased by 29%. In patients not yet eligible for ART initiation also increased by 14%, and the percentage of patients in care on ART increased by 9.4%. We posit that this is likely due to an informal loosening of eligibility criteria, or essentially a positive spillover effect. There was also no evidence of negative spillover effects in always eligible patients, and overall implementing new guidelines increased ART initiation by 9.7%, and the percentage of patients in care and on ART by 7.4%. Additionally, we estimated that increasing initiating an ART in patients with a CD4 above 350 resulted in about a 25 to 30% increase in retention and care. And then lastly, about 70% of patients still are presenting at a more advanced stage. 25% of eligible patients are still not initiated on ART by 3 months, and about 40% of eligible patients are not in care and on ART at 6 months. Based on these results, we believe that we will likely see similar improvements in the number of patients on ART and retained in care without the associated negative spillover effects as we move into the era of treat all. Nevertheless, depending on the underlying patient population, the overall effects of expanding ART eligibility alone may be modest, and substantial efforts are still needed to improve earlier diagnosis and linkage to care, as well as keeping those patients retained. Further evidence is still needed into the real-world effects of treat all, specifically its effect on virologic suppression, a better understanding of those patients eligible for ART that still don't initiate or drop out shortly after, and then also targeted interventions for these patients that don't benefit from eligibility alone. Lastly, quasi-experimental research designs are a powerful and necessary tool to understand the effects of real-world implementation of evidence-based interventions. Thank you very much.
Thank you very much, Dr. Modi. We have time for 2 questions. Please step up to the microphone, identify yourself.
Thanks for a nice presentation. One of your slides said
Can you please introduce yourself?
I'm Dr. Bibiriwari from WHO, CRO. Thanks for your presentation. One of your last slides, you said 70% of patients presented the advanced stage, and roughly that we take as less than 200, but that is pretty higher than our average of 30 to 40% globally.
Yeah, sorry, to correct the advanced stage, I mean patients who would, I meant it by the patients who are eligible by the 2010 guidelines, so they either had active TB, WHO's stage 3 or 4 disease, or had a CD4 below 350.
Okay, thank you very much, Alok. Great presentation. Our next presenter is Karen Webb. She is an operational research director at OFID, the USAID's facility-based care and treatment partner in Zimbabwe, and she has been involved in supporting several health facilities within Zimbabwe. She's a doctoral candidate at the University College London, and she's been looking at some of the challenges and barriers to service uptake in Zimbabwe. And she's going to share with us her data on pre-ART peak and plateau, some early lessons from Zimbabwe on the operational impact of the pre-ART mop-up on ART initiation rates under treat all. Over to you, Karen.
Thank you very much, and thank you for giving space on the panel for an implementing organization to present data that's embedded in the Ministry of Health and Child Care on the early lessons in Zimbabwe from the operational impact of what we've come to call the pre-ART mop-up on ART initiation rates under treat all learning phase. So as a bit of background, in Zimbabwe, like many countries in the region, we have a declining yet high HIV prevalence of 14.6% among adults. And within the OFID-led FACE HIV program, we provide support to 650 plus health facilities in 24 districts across the country. So within this context, in June 2016, the Ministry of Health and Child Care began implementing a treat all learning phase. So it wasn't a pilot, there was intention to roll out the guidelines, but the goal of the learning phase was to document the key operational and outcome lessons so we could inform the guidance, rollout, and optimize rollout. So a key question within this context was what we call the pre-ART mop-up. It's this group of previously ineligible clients based on 2013 guidelines that were not initiated previously and under treat all should be brought back into care. So because this session is as much about the how-to as much about the outcome, to implement the pre-ART mop-up, we had a number of activities through support from PEPFAR and USAID. So this included community roadshows and demand generation activities, production of patient education materials, advocacy, and then cascading treat all sensitizations, guideline sensitizations through existing ministry channels from provincial, district, right straight through to getting the guidelines into facilities. So really the crux of this was health register review, the paper-based registers. It was going through trying to identify the HIV-positive individuals who were previously ineligible for ART and bringing them back into care for initiation. And we had no idea pragmatically and practically how this was going to work. But we knew we needed to add additional support to the facilities to return these clients to care. So we provided additional clinical mentorship at the facilities for the nurses to conduct this tracing and callback systems, so developed standard operating procedures, and then added additional human resources for health to bump up the existing limited resources at facilities. And then to do the callbacks, we provided an additional $10 a month in airtime to the nurses and logbooks so we could keep track of who is being contacted and how. So the primary objective of this program assessment was to establish the proportion of patients initiated on ART from this pre-ART mop-up as a perspective of the total number initiated following implementation of treat all. So to really understand what this means, we needed a series of secondary objectives and questions, which included, well, what influence will treat all practically have upon ART initiation rate increases over time during this learning phase? Who are the clients that we're going to be bringing back into care? Who can we find? And what are their characteristics? And what are the operational lessons and experiences? What worked, what didn't, and how can we make it better for scale? So this is kind of a conglomerate. The learning phase was intense. It was initially intended to be 3 months. We extended it to 6 months so we could add a little bit more beef to the data. But it was a collection of a number of different rapid programmatic assessments using routine data. So within this context, there was 92 purposely selected PEPFAR prioritized health facilities, and these facilities are prioritized based on serving large numbers of clients on ART. And this was over 7 districts. So there are 3 kind of main assessment angles that I'll present today. One is the routine reported aggregate facility level data from our program. These are PEPFAR indicators, with the primary indicators of interest for this purpose being those newly diagnosed as HIV positive versus new ART initiations. And then a second element involved understanding who the group was that was being initiated under Treat All learning phase in Zimbabwe. So this was done at the 2 inception districts, so the very first districts to implement Treat All in Zimbabwe. We did a retrospective register tracing at 29 health facilities to collect the individual level characteristics. And then finally, at the end of the learning phase, we went back and asked healthcare workers, what were your experiences, what worked, what didn't, and how can we improve things for healthcare workers moving forward. So looking at the aggregate, the kind of big picture, big number of what the impact of this Treat All learning phase was in Zimbabwe, we can see that over the period of interest from April to December 2016, there were 9,265 individuals diagnosed HIV positive, yet there were 9,875 individuals initiated on ART. So generally, we would expect the number initiated to be less than the number diagnosed. So this is already some evidence that the pre-ART mop-up was successful. And that in paired t-tests, we showed that the mean number of ART initiations increased sharply 3 months after versus 3 months before Treat All from May to August 2016. And as we were looking at that cascade, we said, we've seen this before. Where have we seen this before? And it was actually presented by my colleague Grappa Mujaranti at the last IAS conference in Vancouver, in which we saw that reported the increase in ART initiations amongst pregnant and lactating women following implementation of B+. So we see this rise above the newly ART initiated versus the newly diagnosed positive, and that after a certain point we see a plateau, a reduction down. You've mopped up everybody back into care, and then you have a mop-up crossover where your new initiations then dip back below your newly diagnosed. But for the purposes of this talk, we're focusing on the Treat All, a much broader population. And so this represents the proportion of ART initiations by newly diagnosed HIV positive. So there's 4 key messages that we feel can be taken home from this learning phase, and that's that pre-Treat All, the proportion initiated at ART, if we look at that dashed line, that's our facility-based second 90. So if 90% of everybody that was diagnosed HIV positive was initiated on treatment, we should reach that line. And we can see that before Treat All, there was a big gap. And that immediately after the introduction of Treat All, we saw an increase above the 100%, peaking at 160% in month 2. And that post-Treat All, we saw the mop-up crossover, whereas it was at 3 months under B+, we saw it at 6 months in the learning phase in Zimbabwe. And that the plateau rates in the last section, we see that after the plateau and we have that dip crossover, it's at a significantly higher rate than pre-Treat All, and it's above our 90. So is this our way of reaching a facility-based 90? So it's not just about, in aggregate data, we often don't know who's within that data, and it's very hard to identify the groups that might need extra attention for rollout and support. So we did a descriptive analysis among the cohort of patients initiated on ART in month 1 of Treat All at 29 health facilities in these 2 inception districts. So this was 504 patients. So within this, 55.2% were ART initiated after being diagnosed new HIV positive. So after the treat all start date, they came in, they tested positive, and they were initiated. And among this group, 47.8%, almost half, were initiated on the same day as diagnosis. And this is being talked about in a lot of other sessions and has different implications. But for us now, we're looking at the 44.8% that were ART initiated following return to care. So they were diagnosed pre-treat all and return to care. And their main characteristics were that they were female with a median age of 36 years. And I found this really interesting. The median days from diagnosis to initiation, we didn't know how far back we would be able to return people, was 398 days, so roughly a little over a year. But the interquartile range ranged from 116 days, which is about 3 months, to about 4 years. So it was successful at initiating patients who were diagnosed positive a number of years back. And then just comparing our pre-ART mop-up versus treat-all diagnosed and initiated proportionally, we can see that there's more females, but this wasn't significant. And then within the age groups, we can see that there were differences, but I just want to draw attention to two main things. And one was in the 6 to 14 group, which would be previously not have been immediately initiated pre-treat all. We see that in the pre-ART mop-up group, we have had some success at bringing children back into care. Unfortunately, the complexities of establishing the pre-ART mop-up denominator, like the total number of pre-ART patients and their characteristics, is very resource intensive, and so we haven't done it as yet, and we intend to do it in the future. But maybe a warning call that we're seeing here is amongst this 15 to 24 age group, which weren't brought back into care as the same proportion as the newly diagnosed. And we know this is the group at greatest risk of new infections in Zimbabwe. And then in terms of evidence of care at 0 to 3, 3 to 6, 0 to 6 months, the pre-ART mop-up group were more likely, and were proportionally greater to come back into care. And this works with the unstable and stable client argument as well, in that the pre-ART mop-up group have care experience in care. And so what worked and what were the challenges? Going back in the post-experience surveys, healthcare workers were saying community mobilization and awareness were essential for generating demand. Systems are essential for keeping track of the client successfully returned to care. And then in terms of callbacks and reaching clients, callbacks worked better than text messages. So they actually switched to the system of calling back rather than texting a client to say, come back into care. And this deserves a lot more, I think, implementation science to explore in greater detail. And that, in general, the healthcare worker perceptions were high acceptability of both healthcare workers and patients. They could see the long-term benefits of this, and came from one quote: patients no longer want to wait to be ill and want to be well-informed. And we just have to make sure that we provide the highest quality of care possible. And then finally, challenges, persistent challenges, completeness and accuracy of paper-based registers. Extra human resources are required in this initial scale-up period. And then, of course, system and efficiency bottlenecks that existed pre-treat all do not go away with treat all. So as a program assessment, we have a number of limitations. It was a 6-month intensive learning phase with a number of rapid assessments, and we were providing feedback to the Ministry of Health month on month, and the PEPFAR technical partners, technical working groups that were established. So one of the key things for this analysis was the difficulty in establishing that baseline pre-ART population and the availability, accuracy, and completeness of the registers. But what an interesting effect that we saw by doing this assessment is we noted a lot of gaps in the registers and a lot of gaps in documentation, and produced job aids and standard operating procedures to try and strengthen it. So when we've been going back subsequently, it has been getting better and better. And then, of course, these type of assessments lead to more questions often than they do answers, and there's a lot of key implementation research questions arising. So in conclusion, treat all increased ART initiation substantially, will require additional resources to do well, and then after approximately 6 months, we saw this pre-ART mop-up plateau, and is this our return to care threshold? After 6 months, are we going to find anybody else? And then ART initiation rates to new diagnoses remain significantly higher than before treat all. And so maybe this is a great strategy for reaching our facility-based second 90. And then it's a great pragmatic springboard for other research questions and program improvements. So I love this picture. I think this is a great, we've got a lot to do and a lot of vigilance, but from the treat all learning phase in Zimbabwe, really we're in in the era of universal HIV test and treat, which is really exciting. I'd like to thank the Ministry of Health and Child Care, the provincial medical directorates for all the treat all learning phase districts, and then PEPFAR through USAID through their support to the entire program, and particularly for the treat all learning phase.
Thank you very much, Karen. I'm afraid you've gone beyond your time, so we don't have time for questions, but feel free to approach Karen at the end of the session for her to respond to any queries you might have. And can the person in charge of the sound system please leave this mic on so we can let speakers know when they are exceeding their time. Okay, so we are ready to move on. Okay, our next speaker is Dins Gotham, who, just to illustrate that we can have professors and medical students speak in the same session, Dins is a medical student who is currently studying for his medical degree, and he holds a Bachelor's of Science in Global Health. So he is going to address us today on the issue of generic treatments for HIV, hepatitis B, hepatitis C, TB could be mass-produced, and giving us some idea of what those costs are involved. Over to you, Dins.
Thank you very much. I recently finished my medical studies, but I did not update my biography. So thank you very much for the opportunity to present this research here, in which we show that generic treatments could be profitably produced for less than $90 per patient for these top 4 infectious killers. I have nothing to disclose. So a little bit of background on the idea of independently assessing the cost of production for medicines. In general, there's little understanding among, let's say, medical professionals and policymakers of the costs of drug production, and there's a near total intransparency with regard to the industry on this point. Now, in HIV/AIDS, in 2001, Yusuf Hamid from CIPLA, his announcement of $1 a day price triggered dramatic price reductions, a cascade of price reductions, which have led to 19.5 million people being on ART today. And in 2014, Dr. Andrew Hill, a co-author on this study, estimated the cost of sofosbuvir to be $100 approximately for the full 12-week treatment. And at this point, it was based on similarities in chemical structure and synthetic process between sofosbuvir and ARVs, which were already generic. And now after that, we found that there's actually data on active pharmaceutical ingredient being exported from India. And so we could actually see the price of API currently being sold out of India, being shipped out of India. And we started using this API price data and building a costing formula from that. And we've now, in fact, costed drugs for Hep C, Hep B, multi-drug resistant tuberculosis, all of the solid oral medicines for which we had data in the WHO essential medicine list, and even a few cancer medicines on top of that. Just to quickly illustrate the global burden of disease for these diseases, which is more than 4 million people put together. Okay, and the methodology works by first, like I said, identifying the cost of the raw drug or the active pharmaceutical ingredient, API. And we use data on exports, as I said, which is actually published pursuant to Indian customs regulations, which they changed in November last year. So now we don't have this data, and this is why our time frame stops there. And after we identify the cost of API, we look at various cost components of turning this raw drug into a tablet that a patient can take. We add margins for profit and for taxes, and then we set that price in context by comparing it to current lowest prices across these 3 sources. So Doctors Without Borders reports, the Global Drug Facility for Tuberculosis Medicines, and World Health Organization reports. Just as an example of the raw data, this is API exported from India, API of tenofovir disoproxil, or TDF, and it's color-coded by the destination of the export, and these yellow dashed exports are going to Southern Africa, and the red full lines are going to Eastern Africa, and in fact Cipla runs a ARV producing plant in Uganda, so this may explain that. Oops, someone's left their glasses. Okay, and you can see from this data that 10 TDF, depending how you average the numbers, probably costs around $150 to $200 per kilogram, and by the linear regression that we used, it's actually $159 per kilogram, and 1 kilogram is enough to treat 9 people for 1 year. Now, to look at sofosbuvir exports, you'll see that the trend is a bit more dramatic than for TDF, and it's perhaps plateauing here at the end. It's reduced nearly 5-fold in about 1.5 years, the cost of API, that is, and it's plateauing at around $1,000. And when we take a 6-month weighted average, that's $1,050 per kilogram, which is enough to treat 30 people. And so this is the formula we use in this study. We start with the cost of API, which is $1,050 in this example of sofosbuvir. You need 36 grams of API to treat someone for 12 weeks, and this costs you $35. Then we add 1 cent per tablet, and I'll talk about that assumption in a moment, for formulation, for making the API into a pill, and that makes it $36. Adding packaging takes you to $37, and adding a profit margin and tax of 13%, that takes you to a final generic price of $32 for sofosbuvir currently for 12-week treatment. Now, just to talk about that 1 cent assumption, we looked at all the published analyses of production cost we could find in the last 10 years, and here they are. And we also actually looked at the lowest priced products across the UK, South Africa, and India. And the orange part is just a range. The cheapest one was in India, and the top one was in the UK. And so for these ones, what we're positing is that if you look at the cheapest tablet in the whole country, if the raw drug for that costs $0, then the whole price of the medicine could be used as a conservative estimate for what formulation costs. And across all these estimates, the line we draw is there. That's the 1 cent, which we believe is relatively conservative. And after this formula, we then compare our predictions to the current lowest prices, which looks like this. So these are the HIV medicines included in this study. And you can see in a few cases, like abacavir, we've actually overestimated. So anything above the line, our estimate is higher than the global lowest price, and anything below the line, we're actually estimating that price reductions could still be possible. This is entecavir, I should clarify, for hepatitis B. These are the first-line tuberculosis medicines, where we've also slightly overestimated, you'll notice. And then these are the hepatitis C co-formulations, where we find that price reductions would still be possible. So putting this in context for sofosbuvir decladisvir, these are the current prices in countries. I'll point out that for the US, we report separately the Medicaid reported price and the price to the Veterans Affairs Committee. And where in the US, this is about $96,000 to $143,000, we estimate that it can be made profitably for $47 for 12-week treatment. To summarize the data presented today, slightly dense slide, but I'll draw your attention to these drugs and prices, which are probably the most favored first lines for HIV, hepatitis B, and hep C and TB. For entecavir, you could use TDF, of course. And across these examples, you can see that all of them happily sit below $90. There are some limitations to the study. We don't include transport costs, bioequivalence trials, or registration, and we don't include costs of pre-qualification. However, we find that there's good predictive ability anyway, as shown in the validation graph. And the after-tax profit margin of 10% may offset not being able to include these. And another limitation is that we only use data on exported API. if the API were produced in-house, so in the same company that formulates the drug, or if it was procured domestically, presumably it would be cheaper. And I say that to point out that we have limitations both which would tend to cause us to underestimate the price, but also limitations which would cause us to overestimate the price. Now, we've previously done estimates for Mdr Tb medicines, and here they are. I've included only kind of the newer ones with more interest, just to save space. These are our target prices for a 6-month treatment. And then we've also looked at the regimens, so the newer regimens that are being investigated. So StreamArm CND are bedaquiline-containing regimens, and these are the target prices for those. Those are slightly above 90. However, if we look at the average TB case, in which 95% of TB patients will be drug sensitive and 5% will be multi-drug resistant, and we say that the current global drug facility price for the drug sensitive TB patients is $27 for the full course, and the 5% with Mdr Tb, the course is our highest estimated production cost for a full regimen, which is $359, and we just do a weighted average between these two. We can say that for the average TB case, including Mdr, the cost of treatment could profitably be $44. Just to summarize all that, these are our headline results, and a few notes of what the implications could be. Firstly, the $90 per person could now become a ceiling price for treating HIV, TB, and viral hepatitis, which together kill over 4 million people a year. It's what we call the new 90-90-90. TDF, lamivudine, and efavirenz are generic. It should say almost worldwide. We're not quite sure that TDF is generic quite everywhere, but it should be nearly everywhere. And this combination, because it's generic nearly everywhere, should be available below $90 per patient. An estimation of cost plus price is feasible and valuable for improving transparency, which is lacking. And in fact, there's precedent for governments using these sorts of estimates, although sometimes they don't do it themselves, but they ask the companies to report it. There are examples in India, South Africa, China, Bangladesh, Iran, and Pakistan, and those were the ones we were able to find in a short search. That there may be more examples. Thank you very much.
Thanks very much, Dan, and I really like your new 90-90-90, and I'm sure your presentation will be quoted in many places, so be aware. PDF your slides. We have time for questions. Yes, please, mic on the left.
Hi, I'm Gesine Meyerath from South Africa. I think this is exceptional. I also believe it's pretty novel, so well done on that analysis. I have a short question, and I'm taking a bit of an issue with your costing methodology. So if I'm not mistaken, the purpose or the main purpose of this analysis, how it could be used, is to get at exactly the profit margin that companies are adding on the cost of producing those drugs. So I was surprised to see that you had actually put in an 10% profit margin into your assumptions. So firstly, what is that based on? And then secondly, shouldn't you rather be trying to estimate the cost of transport, research and development, which will be very hard, I would imagine, to cost, but add those in your baseline and then compare to, take the profit out and then compare to basically the prices to get at the profit margin that companies are taking home at the moment?
Right, that's fair enough. I guess the question is about the kind of general purpose of the study, or what it's trying to look at. I mean, I don't. The main purpose of the study isn't to look at, or wasn't to look at, originator margins. You know, originators publish very little data on their internal expenses. It's really to look at what would be feasible. And you know, of course, I agree about other costs like transport. You know, it's just that we don't have data on that, and we find that these assumptions still reasonably predict it. There are some assumptions, like an IMS health report suggests that the cost of transport and tariffs and import is around 10% on average. So we could add this, but it feels like an unsatisfying and vague estimate.
Unfortunately, thank you very much. Unfortunately, we don't have time for more questions. We are a little bit behind time. So thank you very much for this presentation. It's now my pleasure to introduce Maria Cristina Pimenta from Brazil. By the way, Brazil, the first country having introduced the treat all policy, years before actually the recommendations were made. Cristina has a PhD in collective health research, coordinator of the Ministry of Health, STI, HIV, and viral hepatitis department. Is also university professor at the School of Nursing of Veiga de Almeida University in Rio de Janeiro in Brazil. And Cristina is going to talk about, very much building on the previous talk, making a comparative analysis of ARV costs before and after the clinical protocol and therapeutic guidelines for the management of adult infection was actually adopted in Brazil 2013. Cristina, please.
Good afternoon, everybody. Thank you for the introduction, Gottfried. The work I'll be presenting today is a comparative analysis of ART costs under the prior therapeutic guidelines implemented in Brazil and the present clinical protocol that was adopted for the management of adult HIV infection in December 2013. The study was initiated in 2016 and it's being finalized now in 2017. The primary authors are Lia Hasenclever and Dr. Frederico Rocha, both from the Institute of Economics of the Federal University of Rio de Janeiro. And this study was done in collaboration with the team at the National HIV/AIDS Program. I have no conflict of interest to declare. Just some points of introduction just to contextualize. We decided the study was conducted at a time where WHO had introduced its consolidated recommendations for early treatment and treatment for all. The Cascade had been adopted as a monitoring tool, and Brazil had recently adopted the new treatment protocol that establishes standardization of treatment and the practice of early treatment and treatment for all. So there were many questions being raised and regarding the possibility of extrapolating costs with ART in Brazil for all diagnosed patients and creating a possible unsustainable HIV response. So we decided to conduct this study where the general objective was to calculate and compare the costs between the antiretroviral treatment structure used until 2013 and the new treatment protocol adopted by December 2013. The specific objectives were to evaluate if the number of patients and the resulting increase in total costs would be counterbalanced by the reduction in average costs as consequence of standardization and simplification of treatment, considering the 2020 timeline. To analyze the economy resulting from the simplification and harmonization of treatment regimens in the different scenarios under the new treatment protocol, and to calculate the cost for the expanded use of ARV for HIV treatment for all and treatment as prevention. The methods used, the total cost of treatment was calculated using a mathematical model where AJT is the average annual cost of treatment regimen and regimen J of ERT. And QJT is the number of patients under regimen J of ERT. The drug prices were based on average US dollar price of drugs of the purchase period. And here we might have some drug prices that were actually drugs produced in Brazil, but we averaged the price in dollars so that we could have average price for the most common regimens used. Quantities were defined by the prescription guide of the adopted protocol at that time, and the comparison of regimen costs in the two periods were from 2009 to 2015. So the data collected used the MOH, Drug Logistics Control System, CICLOM, the Control System for the National Laboratory Network, CICEL, and the National Price Registers for the acquisition of ARVs. Comparison of treatment regimens used were from September 2009 to December 2013 2013, and from 2014, September 2014 to December 2015, composing two scenarios, before and after the adoption of the new standardized treatment protocol. Because then if you use the patients at the end of the year, you make sure you get all of the patients that were on treatment that year. Selection of study population were all adult patients under treatment in the periods considered. The study population were then all the patients under treatment during the year who had their last prescription between September 20th and September 31st. That is, all patients who received at least one prescription at that period. And in 2009, we considered 207,014 patients, and from September 20th to 2015 and December 31st, 2015, 444,000 patients, and all the under 18 patients were removed. Each treatment regimen is composed of a combination of ARVs, so the cost of treatment is the sum of the drug prices multiplied by the daily dosage specified by the 2008 treatment consensus and with the new protocol consensus adopted in 2013. So there were 4 scenarios created for the 2020 in the study, parallel to the UNAIDS 1990 targets. The adoption of the adoption of the population growth estimates were used from the Brazilian National Institute of Geography, which is our national census institute. The adoption of the estimated growth parameters of the HIV-infected population were used considering the general population for the country, ranging from 0.4 to 0.7%. The scenarios created were the maintenance of the incoming patients into the system in the 2015 levels, which were close to the lower level of UNAIDS targets, the growth rate of incoming patients of 10%, the growth rate of incoming patients of 20%, and growth rate incoming patients of 30%, which then would be closer to the higher level of the UNAIDS targets. Considering the estimated rate of entry and exit from the system in levels observed from the evolution of the treated population from 2009 to 2015, and the distribution between first-line, second-line treatment according to the evolution of the patient population present in 2009. And we use the 2009 parameter because our data became more consistent, our databases became more consistent in 2009. So some partial results that I have here, you can see in this table, looking at these results, these are the 10 most frequently used regimens for patients we have. And for 2009, we considered 207,214 patients and the 444,000 patients for 2015. So this is a 2009 and this is 2015. And these are the most frequently used regimens. Then we also have a table here with the number of patients considering the most frequent regimens by number of treatment for naive patients. So those would be the incoming patients for 2009, 2015, and the total didn't come out here, but it's for 2009, we have 37,819 incoming patients, and 2015, we had 73,465 new patients. The total costs in 2009 by total number of patients and incoming patients. So on the left side is the total. Where is it? Okay. For total patients in 2009. And in the right column is for incoming patients in 2009. So the difference in 2009 was that for the total, we had 61 million $61,793,000, and for the total, as a total cost for these 10, considering these 10 regimens, and for the incoming patients, it would be $5,300,000. Now, for the cost for 2015, by total number of patients and incoming patients, we can see the difference where we have $150,219,000 for as a total cost, and for the incoming patients we have $12,346,000. These were the scenarios for treatment expansion, but I'm not going to go into that because we don't have time. So I'll just go into some of the conclusions, and if we have time, we can talk a little bit more about that. So compared to the average cost, so the findings do indicate a decrease in the average costs due to the standardization of treatment regimens after 2013. The difference is even more important in the incoming population. So that you have an idea, before the simplification of treatment and standardization of treatment, we had almost 1,500 possibilities for regimens, of treatment regimens in Brazil, and now we have about 500. So the difference is even more important with the incoming population, because then the incoming population starts in the simplification, and the other ones are being considered for the changes. The initial decrease in costs based on the increasing number of patients entering the system are compensated by the reduction in future costs with differentiated treatment and hospitalization costs. We do have a limitation in this study because we didn't look at the service costs, but we have data on the CD4 and the viral load of the patients, and these indicators were improved. So we can infer that the cost with services will also, and hospitalization will also be reduced. The significance is that the total cost for ART for patients in 2015 has an average cost of 41.46% less than in 2013. The economy allows savings for more than $250 million per year. And compared to the average cost of 2009, the total annual cost of patients in 2015 would be 70% higher if the new protocol had not been adopted. So this is enough to cover for 670,000 new patients and more than compensate for the adoption of the early treatment and treatment for all policy. So results become, as I said, even more relevant since cost savings were accompanied by a better clinical outcome of patients based on the data for viral load in CD4 that showed a significant improvement of these indicators. I didn't bring this data here because, 10 minutes is not, enough. I'm done. Just some acknowledgements, of the team members and funding. Thank you.
Thank you very much, Dr. Pimenta. Unfortunately, you've used up your time, so we can't take questions at this time, but I'll also encourage those who have questions to please see her straight after this session. So our last speaker for this session is Dr. Valerie Ellis Francois, who works at Cascade in Haiti, and she has an outstanding track record of having played an important role during the earthquake, for which she was recognized. And right now she's sort of leading the charge as the coordinator of the PEPFAR activities in Cascade. So let me hand over to you, Dr. Francois.
Thank you for the introduction. Bonsoir tout le monde. I will be presenting the last abstract for tonight. It is titled The Index Partner Testing and Targeted Case Finding in Northern Haiti. Last but not least, hopefully. For those of you who don't know, Haiti is a French Creole-speaking country located in the Caribbean region with a population of 11 million people. The HIV prevalence is 2.2, but among men, it's 1.7, and it's almost double among women. An estimated 200,000 people are living with HIV, and more than half are currently on treatment. This is a map of the prevalence by region. There's a wide variation, as you may see in the border area with the Dominican Republic. The prevalence is higher with 3.9, and the coastal areas is 3.2. This abstract was written in the context of the SSQH project. SSQH stands for Service de Santé de Qualité pour Haïti, which is a project under the Maternal and Child Survival Program, which is led by JPIGO and funded by USAID. SSQH supports the Ministry of Health of Haiti and providing quality health care to the people of Haiti in almost 166 sites. We focus on improving outcomes of HIV, maternal health, family planning, and Zika. We also support the National HIV Program and 46 sites, providing a complete package of HIV services. HIV testing services in Haiti are provider-initiated, available in all 46 HIV sites, supported by SSQH, also in mobile clinics and remote communities. Targeted testing approaches aims to reach highest risk population, but yields have been very low compared to the national prevalence, ranging from 1.3 to 1.9. Unfortunately, community health workers do not provide HIV testing in Haiti. Not yet, only trained providers. In 2016, USAID PEPFAR focused on index partner testing in an effort to identify more patients living with HIV and link them to care. Also, new national guidelines recommended testing for partners of patients, but uptake and documentation were very low. While some healthcare providers still offered partner referral for testing, it is not prioritized, and the delivery was very inconsistent. So the method used. In October 2016, SSQH provided training to 20 sites in northern Haiti. The two-day training addressed targeted case finding, strategies supporting clients to refer partners, counseling and communication messages were also shared. A monthly reporting template was issued to sites to report key indicators for index partner referral. Providers reinforce counseling for index clients on partner testing. Data were reported by 20 health facilities in the northern of Haiti during a 6-month period. JPIGO staff transferred data to the database, and descriptive analysis was conducted to assess the scale of index partner testing. This is the index partner testing cascade. From October 2016 to March 2017, more than about 600 patients were tested positive for HIV, and 88% accepted partner referral counseling. Only 22% accepted to refer their partners, and half of them actually showed up to the clinic. 49% of those partners were positive. There are a few challenges at all levels of this cascade. 12% of the newly diagnosed HIV-positive clients were unwilling to receive counseling on partner referral. 78% of those counseled on partner testing still decline to refer their partners, and 46% of partners referred by index clients did not show up for testing. Among the partners who were tested, half were serodiscordant couples, which may include current and old partners. Also, challenges reported by providers. Newly diagnosed clients may have other concerns or priority than partner testing, including initiation on ART, stigma, discrimination, and also gender-based violence. Resources were limited to support index client to bring in partners, and also cultural factors play a huge role in Haiti. Gender inequality, superstition, religion, including voodoo, and migration. Some limitation of the study. This was a first attempt at describing and understanding index partner testing in Haiti. The data collection tool was quite limited. Client-level data was not standardized. Sites reported only aggregated data which cannot speak to gender nor age differences, type of partner, and relationship. Future training may be needed to focus on supporting clients to develop disclosure plans and skill building for different approaches to partner notification and testing. As a conclusion, I'm on my time. Training and equipping providers with monitoring tools, supporting them to better counsel newly diagnosed clients on partner testing can lead to identification of HIV-positive partners and discordant couples. Despite challenges, testing partners is effective at fighting new patients living with HIV and can be effective at linking them to care and treatment. Recommendation and next step. Client-level data collection tools are needed to be able to better describe the population of index clients and partners they refer. Providers need more training to support clients in developing disclosure plans and identifying strategies to refer their partners. Additional studies may be needed to understand reason for accepting or not accepting partner notification and testing. Additional strategies for supporting partner testing are needed, including introduction of community home testing by community health workers and peer educators, and HIV self-testing in Haiti. Further efforts are needed to strengthen this targeted testing approach, including ongoing counseling and support for index clients to disclose in order to achieve the 90-90 UNAIDS targets in Haiti. I would like to thank the IAS for allowing me to present this study today, the funders, USAID, PEPFAR, the Ministry of Health of Haiti, and the National HIV Program, the JPIGO team, MCSP, SSQH, and last but not least, my co-authors, who some of them are here today, Sylvia, Stacy, and Cristina. Thank you so much for your support. Thank you. Merci de votre attention.
Thank you very much. That was superb. So you kept on time. Really well done. We have a few minutes for questions. So let me invite the audience. We can take one or two questions at this time before we wrap up.
Any questions?
Yes, go ahead.
Hi, thank you very much for the presentation. My name is Christian Stilson from Malawi, and I was curious if in the index patient testing you were also making referrals for children of or family members of HIV positive people testing. Thank you.
Yes, that's a very good question. We actually do referrals for OVCs, but it was not included in this study. We actually do referrals as the population according to the fertility rate of the country, which is 3.5. So we do encourage the sites to enroll OVCs according to the number of clients that are enrolled in the sites and the fertility rate of the country. So we do have quite a lot of OVCs for the 200,000 patients, even with HIV. Did that answer your question, sir?
Great, thank you. Last question from this end.
Good day. My name is Stevie McGill. I'm from Liberia. I just want to know how you're dealing with the barriers in terms of the myth around HIV and AIDS, especially in a country where they have voodoo and culture. I come from that same cultural background like in Liberia. We've got people who will have HIV symptoms and they was in great denial of just accepting their status. Like they would prefer going to the bush doctor to get treated.
Exactly.
And most of the time that's happening. How are you breaking that?
This is one of our most difficult obstacle. Actually, about 65% of our clients that are lost to follow-up have had like a visit to the voodoo priest housing. So we've been trying to work with them, with the voodoo priest, to actually encourage them to refer the patients to us, to the nearest HIV facility. And also we have a lot of group support that include those leaders, community leaders, which are the religion, the priest, the voodoo priest, and also we involve the political committees of the communities. I don't know if you have any advice for us, because like I said, that's one of our most difficult obstacles so far.
Good. Thank you very much, Dr. Francois.
Thank you.
So we heard in the session that we can really get out there and get the testing done through index testing. We can get the case finding done. We heard about how drug costs are somewhat inflated if you take what the costs of API are and what the costs of manufacturing and so on are. We got some sense of what it costs in real practice trying to do this in Brazil. And I think we're getting a better and clearer understanding of how Treat All is impacting on the real services. In some instances, it's enhancing retention. In other instances, it's bringing new patients into the service. And we're getting to get some sense of even mop-up operations in some countries are able to draw in the new patients. And finally, we're understanding that in all of trying to do this, there are many challenges. And those challenges get particularly acute when we start talking about sparsely distributed populations, when we start talking about areas where access to healthcare services are low, as we saw in Malawi. So I think we were treated to some really good research and some interesting findings from implementation and from programs and from mathematical models and from estimates of drug pricing. And out of all of that, we've got some ideas about some of the challenges we face as all of us try to take on the treat all message. I'd like to, on behalf of Gottfried and myself, let me just give him a chance to make a short comment, and then I'll wrap up by thanking our speakers.
Right. Thanks for the brilliant summary and to the speakers, but I just want to go on record by saying Treat All is very much underpinned by health equity. I think it is clear that we must not compromise. We must look for efficiencies where we can. If needed, we must adjust service intensity and service access to where the people live, of course. But I do want to make it very clear that I think we should walk away from this session to reiterate the need for keeping health equity, and that includes key populations, as Mareike had made a strong pitch in the opening statement, and that we do not want to compromise on that.
And just to end, to say that we're very pleased to have in our midst some very senior investigators in this panel, but also we had some really young guns. And I want to ask all of you to please acknowledge these youngsters for having done great research, and we look forward to their future careers.